Good afternoon. I'm Dr. Ashis Majumdar here to present umbilical cord patch grafting in corneal perforation and desmetocele, a novel approach. If you are using it, then I cannot use it from here. I have no financial interest. Globally, 1 million persons are blind due to corneal opacity, which is fourth most common cause. And for this corneal blindness, we generally do keratoplasty. For keratoplasty, we need donor cornea, but in COVID pandemic situation, 50% decrease in corneal blindness has been noted. So for that, we need an alternative structure for these dire situations. Amniotic membrane has previously been used for these cases, but now umbilical cord is in limelight because this has more number of collagen and it has mesenchymal cells, which is totipotent in nature, which can be isolated from the subamnion. For this, we have objective of a study. The aim for the study is to evaluate the clinical outcome of the umbilical cord patch grafting for deep corneal ulcer with perforation and desmetocele. For that, we have done one prospective interventional non-randomized single-arm single-center study with 48 subjects. Each subject has been participated and followed up for 6 months, and the entire study has been done for the 1.5 years with 3 phases of the study. From 18 to 65 years old patients has been included in this study with both gender, with corneal perforation due to infection and non-infection of size of 3.5 to 4.5 millimeter with no prior history of keratoplasty. As an outcome, we have taken graft-host integration, corneal thickness over the time period, reepithelialization time, improvement in visual acuity and anterior chamber depth. As an intervention purpose, first we have measured the defect, and then the twice of the measurement of the defect has been cut out from the dried umbilical cord. Then it is fashioned as a circular patch, and it is placed over the cornea and soaked with balanced salt solution, and then it is attached with cornea with 8-10-0 monofilament nylon. Then the anterior chamber is formed with air and BCL has been placed. In this case, you can see there is a desmetocele with vascularization and inflammation. After 6 months of post-op, there is no vascularization, inflammation has been reduced, and there is a good graft-host integration you can see. In this case, a patient has come with corneal perforation due to trauma, who has undergone the umbilical cord patch grafting and also cataract, and the post-cataract vision was 624, unaided. Here, the gradual photograph, you can see there is fluorescent slit lamp examination showing gradual reepithelialization, which is also evident in ASOCT. In this gradual picture, you can see the post-op 3 months, there is a clear demarcation line between graft and host, whereas post-op 6 months, there is no clear demarcation line. In this histopathology, you can see there is epithelial hyperplasia, which is from the umbilical cord. There is granulation tissue which is being formed due to the graft-host integration, the compact collagen of umbilical cord, and below there is a newly formed collagen fiber from the in the cornea. The mean reepithelialization time is 19 days, whereas the mean graft-host integration is 84 days. The mean corneal thickness was 412 micron after 6 months, whereas 206 micron is the mean umbilical cord thickness after 3 months. There is no visual improvement or anterior chamber depth change in the time course. But there is one patient who has developed the hypopyon, 2 patients has developed vascularization, and 1 patient has developed corneal thinning. In the conclusion, we can say that umbilical cord patch grafting can give a good tectonic support. It can be used in corneal perforation and desmetocele in dire emergency situation. It helps reducing the inflammation, and there is a good graft-host integration. It also maintains the anatomy of the anterior chamber. As a limitation, I can say the number of the sample size is less and the follow-up period is less. So we can see for the more longer follow-up period to see the late complications and longer post-operative outcome. These are my references. Thank you.
Nice presentation, Dr. Ashish.
Thank you, sir.
I appreciate you. Is it the whole thickness of the umbilical cord did you use?
No, sir.
Refine?
No, sir. There is a procedure for processing this umbilical cord. We don't process it in our institute. Company does it. So I have I have asked them the procedure, and the procedure is first they cut out the umbilical cord, and the Wharton jelly and the umbilical veins and cords has been removed. Then they only take the subamnion and the amniotic membrane of the umbilical cord, which is approximately 250 micron when it is wet. But then what they do, they just only dry heat it. They do not give any other preservatives or anything. So that reduces the thickness at around 150 to 100 micron. So it can be preserved for longer period, and they just do it ETO and they just sell it like that. So while when we use it, we just get the subamnion part and the amniotic membrane part. So that gives the mesenchyma and also the collagen part of
All
the.
right. The second question is, how do you preserve?
We preserve it in a normal temperature. We don't need to have any fancy like storage procedure. They just ETO the umbilical cord, they double pack it and they send it to us, and then we use it. It can be stored in normal temperature.
And for how long you can store like this after ETO?
The expiry date is 6 months. The company, I have no financial interest. The company, those who sells that, the company name is LifeCell. They give it as AmnioPlus Thick. They have 3 products, one AmnioPlus 1, 2 and Thick. 1 is only amnion, 2 is amnion plus chorion, and AmnioPlus Thick is amniotic membrane and umbilical cord. So this is how they sell it to us, and this is it.
Did you follow up all the patients for 6 months or more than that or less?
6 months is the least.
Least. So
This study,
during the course of follow-up, did you find any change in the thickness? As you said, the umbilical cord was completely integrated into the corneal tissue in how many months? How many weeks?
3 months.
3 months. So is there any changes, any deposition of the collagen under the umbilical cord sheet? Did you find anything change in the thickness of the whole corneal stroma?
Yes, ma'am. I can. This is the picture I would love to show you. Here in this picture, you can see this triangle. There is a compact collagen which is from the umbilical cord, and beneath there is loose collagen tissues which are newly formed, and these are recently I have done CD34 immunohistochemistry. I couldn't present it over here because this is on the process. So they have shown in that picture that there are different collagen. One is the umbilical cord, which is the above part, and down there is the newly formed collagen, which is collagen 4 of the cornea.
So how it is advantageous over the Tenon's page, because it is readily available? Why should we go for amniotic membrane if Tenon's is readily available there?
Sir, the cases where I have performed this amniotic membrane umbilical cord patch graft, the cases are already, the cases who have come to us are already inflamed in nature. So I thought not to put tenons from those inflamed eye where I have already have an alternate tissue where I can just put it over there and not to harm the other eye or that eye, where if the person has come with a trauma, then that eye is already inflamed, and that person is partially blind in that eye. So if I take tenons from other eye, that eye need to be patched for 1 or 2 days, maybe that eye also get inflamed. So why to risk other eye or that eye even when it is an inflamed situation? So for that, if I can use in another structure which is similar to this and which won't jeopardize the other eye or that eye situation, so why not try this?
Thank you.